stage is the one and only Brett Sutton from the CSIRO, fellow podcast host and other extraordinaire as well. Brett, thank you so much for joining us today.
Thanks, Peter. And I wish I had the podcast skills that you clearly have, but
there's still time. There's still time.
Excellent. Well, great to join you and all the other Peters and Daniels and Simons and Davids and anyone else who's got a Old Testament name. Brett was a name invented for children born between 1965 and 75, so you won't see many of us anymore. Great to, well, I'd say see everyone. I can't see anyone other than myself. Great to see me, but great to be here with everyone. And I'd like to talk about why CSIRO is invested in this. The top line is that we understand the enabling environment that data interoperability provides for everything that we're trying to achieve across the health sector, in healthcare in particular. And we know that the coordination of care and patient-centred care and following care along the life journey are really critical aspects that we need to make as efficient, effective, cost-effective as possible for the Australian patient and broader population. My particular bent, however, I'm a public health physician, is both to be an absolute champion of that enabling environment in digital interoperability, but to also push the envelope to whatever extent I can around what it can achieve in terms of impact, which means broadening the view to the biggest population level and to the lowest rung in the prevention ladder that is possible. In the world of public health, we talk about the prevention pyramid, and clinical care is at the top of it. Clinical care is that pointy bit where you can't avoid it. People have immediate and urgent and manifest clinical needs, and you need to treat them, and that care needs to be, as I say, safe, quality, effective, coordinated. But the population health view recognises that you can't hospital your way into full health when disease is already manifesting. It often has a very, very long latency period or incubation period before it becomes manifest and requires acute care interventions, hospital care or primary care, whatever the case may be. But also the determinants that underlie the diseases that manifest in later life are complex and largely sit outside of healthcare or clinical care. 80% of health determinants are outside of clinical care. And so if you want to shift the dial and deliver, as we talk about, healthy and well years for people, you need those interventions to be at scale and to be at the right level, at the earliest possible intervention that you can. It becomes trickier in terms of the causal pathways that lead to disease because they are broad and they are, as I say, largely outside of the healthcare sector, and therefore the KPIs and the responsibilities and accountabilities at a departmental and ministerial and provider level become trickier to determine, but they are nonetheless really important. So what's the pyramid look like? Clinical care at the top, but then there's tertiary prevention. So tertiary prevention is like an early intervention. Secondary prevention is that even earlier, so stopping some of the disease progression that you see in disease pathways, and primary prevention, which is stopping that disease in the first place. And then we talked in public health more recently, not so recently, but maybe it's new to a lot of people, primordial prevention. So at that absolutely fundamental level of the social determinants you might have heard of, social determinants of health or broader determinants of health, which are socio-demographic, economic, environmental, etc. And so when we talk about the 20% that determines health in the clinical world, we're all very familiar with it. Pharmaceuticals, medtech, biotech interventions that make us healthy again or keep us healthy or try and mitigate disease outcomes. But there are a whole bunch of other interventions that, we're broadly familiar with. But if I can give an illustration, if I take rheumatic heart disease, So, of course, people with rheumatic heart disease need clinical care. They might need a valve replacement and then lifelong anticoagulant therapy. But what is the tertiary prevention? Well, it might be a balloon angioplasty, which stops a valve replacement being required, but it might also be prophylactic penicillin to stop that valve disease becoming worse. Secondary prevention, the throat swabs to stop the group A strep sore throat that leads to rheumatic heart disease. Primary prevention would be a vaccine if we had one for group A strep, and lots and lots of people are working on it because it's at that fundamental level where it would potentially stop all rheumatic heart fever. And then at the primordial level, it's dust, overcrowding, the behaviours that keep your face clean, and poverty is probably the biggest determinant of that as an outcome, and really so much disease that poverty is the primary determinant. And so I think there are real opportunities in data interoperability to push the envelope and think about the scope of those important data sets to connect and to interrogate and to link for a whole bunch of reasons. They might be informing the policy landscape for policymakers to have a clearer understanding of the things that are determining those disease pathways and disease outcomes that we're all invested in managing, but to think about it at that prevention level and maybe to have some clearer guidance and clearer understanding of the value proposition of intervening at that earliest possible time. There are some that we are working on much more clearly, but others that are largely neglected because of that fuzziness in the causal pathway. In diabetes, it's very clear. If you need a foot amputation, you get a foot amputation. But we know that an earlier detection of the vascular changes in feet, the temperature changes in feet can stop you requiring that amputation. And we're going even further, better glucose control. At a primary level, weight loss for type 2 diabetes can avoid it altogether. And then at the total ecosystem level, food systems. Now, I'm not pretending that Sparked is going to change the landscape of food systems in society, but it can work at a whole bunch of levels for a whole bunch of diseases in that prevention pyramid. We know that primary care data is an absolutely rich data ecosystem that we have not mobilised and connected to as much as we should, and that the data standards embedding and the data interoperability enabling culturally, technologically, legislatively needs further work. But it could be a really, really promising way to intervene at that, if not primordial, hopefully primordial level, but primary and secondary prevention level to really make a difference in delivering healthy years of life for all Australians. CSIRO has been working on Indigenous health check, which is very much in that space, very much in the primary and secondary prevention level. The kind of things that you check on in an Indigenous health check can stop disease starting in the very first place. But when I think about all of the opportunities that exist in that primary care encounter with your GP, it's innumerable. It's not just for a single disease, it's for a whole bunch of risk factors that can lead to a whole bunch of diseases. And being able to defer, avoid, completely eradicate the possibility of some of those diseases becoming manifest is a really promising avenue to explore. We don't have a proper young person's health check, but if we can embed that in the routine procedure and software that GPs had that draws on all of the information that's required to help fill out what that health check would look like, the HPV vaccination that young people would get, whether in school or a pharmacy or through another GP or through a school council, they're all super important. The BP and body mass index and skin checks and mental wellness and STI screenings that should be part and parcel of every young person's health check. They are really, really critical, and we need to create the enabling environment in a primary care setting that allows it to be a straightforward, almost automated, almost unconscious process for a GP, so that they don't have to scroll through 12 different websites and 50 different screens, and take their time away from being able to provide some guidance to that young person who might be sitting in front of them. I also think that there's a policy landscape that we can really deeply inform through the broader understanding of the factors at play in health. The Australian Institute of Health and Welfare, huge repository of really valuable data, a lot of which is healthcare related, obviously, healthcare separations and the like. That can be really informative, but it also links to ABS data, and it also has that richness of socio-demographic data that can be super informative about where we put our time and energy and focus. Now, I don't know if all of that is HL7 enabled, and maybe that's a conversation that David and I or others need to have with HL7 Australia and HL7 International about what should and could be captured in order to make the most of that data interoperability to drive wellness and to drive healthy years of life. Sometimes it's really invisible, the health outcomes, because we're not capturing the data, or we're not able to capture it in near real time, that I think is sometimes an obstacle for policymakers, because it doesn't have the immediacy as things unfold. And when I think about, the tragedy in Victoria in the Black Saturday bushfires, nearly 200 people died from the direct effects of those bushfires in the same 4 days of extreme heat, and they were days of extreme heat. There was an estimated excess of 350 people who died. Now, that is equally tragic, but largely invisible, and people won't have been aware of that excess in deaths. If we can have real-time views of primary care presentations, prescriptions required, or other data that would inform us about the incredible hazards that were playing out in real time, a heat hazard playing out in real time, then we can have interventions from a policy level, but also from an emergency response, health response level that can be really informative. The same applies for poor air quality. When there are bushfires and PM2.5 levels are huge and we need to wear masks and be inside and turn our filters on, we would do that with greater clarity, in the same way, that none of us want to forget kids in hot cars. We would do it with the kind of immediacy and emergency response. If we understood that there was an excess of 10 or 20,000 primary care presentations or emergency department presentations that related to things that smoke cause, stroke, dead on arrival, dead at home, heart attack, asthma, and other respiratory diseases, I think there's so much opportunity here. So I'm both the super advocate, but envelope pusher at the same time. So I hope the ecosystem can bring that into consideration, because there's a real power in population and prevention health. Thanks so much.
Brett, I feel like that's provided such great rounding for, the why almost, and in hearing from the different partners. Let's bring on all the partners that have just given their piece, and we'll wrap out this session of part 2 from the Sparked Symposium.